and leaders in the healthcare sector. My name is Ibrahim. I'm a radiation oncologist, and I'm the Chief Medical Officer of Burji Medical City. I will not take a lot of time. It's really a pleasure and an honor to have such a high esteemed speakers and actually practitioners practicing medicine at Burji Medical City. We are very proud and humbled to have the Paley Institute of Pediatric Orthopedics. For those who don't know, this is actually one of the top, if not the top, institutes handling all pediatric bone deformities. It's my great honor to introduce the first speaker, which is Professor David. So Professor David Feldman is actually a professor of pediatrics and orthopedic surgery. He practiced pediatric orthopedics at NYU for more than 20 years. He's the associate director for Paley, and it's really a pleasure for him to give us a talk today about his areas of expertise. Please give your hands up for Professor David.
Okay. Thank you, Ibrahim. So, thank you for having me. So I decided today to talk about, they asked me to do some innovations of spine and orthopedics within pediatric orthopedics. So I took two sort of esoteric topics, two topics that are not very common, to talk about, to show maybe how those, we can utilize those in some newer techniques and in an approach to treating conditions. So the first topic I'll talk about is the spine and achondroplasia. Achondroplasia is the most common dwarfing syndrome in the world, and it is very commonly associated with spinal stenosis and spinal deformity. Anybody who has achondroplasia, there's about a 90% chance by age 60 that they will have some spinal procedure done. So it certainly is a healthcare problem in this population. Those are my conflicts of interest. So achondroplasia is a genetic disorder. They know which gene it is, and it's a defect in the disorder of FGFR3. Hypochondroplasia is on the same gene, just on a different part of the gene. So this is a spectrum of disease, hypochondroplasia and achondroplasia. And it's just an overactivity of this FGFR3 gene, and there's lots of drugs now and medications available that are coming on the market that can slow down this gene in order to allow for growth in this population. We just recently published an article with my partner who's here, sitting here, Dr. Hari Haran, regarding spinal stenosis in achondroplasia. And we talk about the risk of revisions and how do you prevent revisions and what do you do to prevent some of these problems. And I'll show you some of that. So the problems in achondroplasia, and I'll only discuss one today, is foramen magnum compression. That's usually a very young age, just at the base of the brain. They end up with having a thoracolumbar kyphosis, which is having a round back at the mid-level of your spine, which is complicated by the most important part of this, which is spinal stenosis. And spinal stenosis, that's how I describe spinal stenosis. Your spinal cord is trying to get through a tunnel, and basically it has no room, so it basically cannot get through that area, and that causes a problem. And all those trucks are the nerve roots, and basically that in itself causes a problem for the nerves going down into the legs. And in achondroplasia, there's a very small area for the spine to go through, or the spinal cord or the spinal nerve roots, because these pedicles are so short. And once we get older and our discs start degenerating, that space becomes more and more narrow and becomes a problem. And so that's the reason why they get spinal stenosis. So it occurs at all ages. It's very variable. It's a leading cause of disability in this population. They become progressively weak. They have intermittent claudication, which means when they begin to walk, they get very tired and they have to actually squat down. And they can get acute neurologic problems. So these are all the symptoms the patients have, from incontinence, they can't control their bladder and bowel, to paresthesias, dysesthesias, leg pain, and low back pain. So this is really what it looks like. Basically, mostly the levels of the discs. Here are the spinal nerve roots coming down, and you can see there's almost no room in the canal for them to come down. And mostly at the disc spaces is where they're being compressed. So we have a questionnaire we ask our patients with this disorder. before they ever have any other surgery is, do you feel weak? You're incontinent? Is your limited walking? Do you have to squat? And is your walking becoming less and less? And this is a patient who's 30 years old who presented to me paralyzed, basically an acute paralysis with a cauda-equina syndrome. So she has this mid-level thoracolumbar kyphosis or round back. At that level, her spinal cord became compressed. She sneezed or did something or squatted down and became acutely paralyzed. And so she was treated, and there's her spinal cord, and you can see there's absolutely no room for the spinal canal for the spinal nerve roots. And so what you do is you can basically decompress the spine and at the same time correct the kyphosis, and at the same time we can we fuse these levels in order for it to not recur. And I can describe why we fuse the levels. The problem is, because there's very little bone in these patients, she did not fuse at L3-4, and she's developing a kyphosis at this level, and it's called a pseudoarthrosis. So to fix that, you can do what's called a minimally invasive interbody fusion. So you can make a small incision on the side and basically put this interbody cage, and never reopen in the back. So that certainly is new. And we do that before we do anything else on these patients and extending her down, and she did just fine in the long term. But it can even happen in a 10-year-old. Here's a 10-year-old with the same kyphosis, and he's also developing really symptoms of stenosis. In that case, you can see once again that he's very stenotic at the levels of his spinal, of the kyphosis. And he too had a shorter level fusion, but basically decompression of the spine fusion to achieve this result. And the decompressions are now performed with ultrasonic scalpels. There are many types of ultrasonic scalpels now, and there are some newer ones available. And that's years later. So now we would go ahead, and even before we start the surgery, we would put this device on the side so they don't develop it, then decompress. Now, even when this patient was in the operating room and they were placed prone, they lost all their motor potentials, which means they became paralyzed. So even in positioning in the operating room becomes dangerous. So what you can do is you can have specialized tables that allows you to do the surgery in a jackknife position. And that allows you to safely continue the operation without the patient becoming paralyzed, and slowly straighten this table as you correct the spine. And so that's afterwards. So could you avoid the fusion? Could you just do a decompression? And the answer is yes, you can do that in select patients who have normal spines. And this patient was just decompressed. So what else can happen wrong? This was done elsewhere, and you can see this patient had a fusion and a decompression. The problem is, above the fusion, they developed a kyphosis and acute paralysis. So in this case, and especially in obese patients, you want to go higher rather than lower. And so that's what happened down the road, and this patient became acutely weak, and 1 year after the surgery, and that can be extended all the way up and decompressed and fixed. Sometimes you have to actually go from the front of the spine to fix that same pseudoarthrosis. So that same patient had a pseudoarthrosis at the lowest level of this fusion, and that I could not get from the side, so I treated from below. So really there is a logical approach to this. You assess the needs, you treat the stenosis, you perform the surgery in the kyphotic position, use ultrasonic scalpels, and you go high if you have to, and you do an interbody fusion. So this really combines all the techniques really that we have in the newer technologies of spine surgery in one specific condition. And that's what we would do today, beginning to end, and not have to reoperate on these patients. And this is just to show you this even could be done in a 60-year-old patient in the same way. I'll show you what it looks like. There's the spinal stenosis. You cannot see the spinal cord at all. And I'll show you, that's what a normal spinal roots look like. There's fluid around the spinal roots. And now watch. And that's what an abnormal spine, you do not see any fluid. The spinal canal is completely stenotic. And again, stenotic. And again, stenotic. All the way down to the pelvis. So this was a 60-year-old woman who was unable to walk, school teacher, who basically had this done. And she's doing just fine. What not to do. This is to show you what not to do in a patient. So some of the newer techniques that we can also do is we can take out a vertebral body. The problem is this patient had it removed, but they left bone behind. So that's a problem. And also, they didn't decompress the lowest level. So in talking about newer technologies, you still have to treat the full condition. So in this case, we had to go back and do this all over again. This is a 56-year-old who didn't have a fusion and just had a decompression. And again, you can see this is not acceptable. He is neurologically, he has a neurologic deficit. He has a bag for his urine. And basically, that is really not the end result that we want. Okay, so now let's switch subjects. So now we'll talk limb reconstruction and what else can be done. So this is a condition, arthrogryposis, which is about 1 in 8,000 patients. And I'll just show you this to show you what can be done surgically for a condition that was thought not to be able to be treated. So this was 4 years ago. And here's the boy trying to walk, and here's the boy after surgery. Here's the boy before surgery. Not braceable. So that's before surgery. So his knees are stuck at about 80 degrees to about 120 or 80 to 110. And he couldn't walk. And this is after surgery. So the goal of new surgeries are that not just to allow for the knees to be straight, which they are, but to allow for more motion. So this is a disease that causes stiff joints. So our goal is to basically allow the joints to move. And that's 5 weeks post-op after having both of his knees corrected. And that's his knees now. He has no muscle to straighten his knees, so he does need a brace to walk. And so that's him 5 weeks post-op. Six weeks. That was during COVID, I guess. Okay. So how do you get there? So arthrogryposis is a stiff jointed disease. It's oftentimes genetic and oftentimes not genetic, probably about half and half. And how do we increase the range of motion of a condition that has very stiff joints? And it has many associated names with it. All of these syndromes cause arthrogryposis, from Escobar syndrome to multiple pterygium syndrome. And arthro just means joint, gryposis means stiff. So how do you make them less stiff? So that's before, And so what we do is we basically combine every new technique of releasing nerves, making the nerves basically freed up, releasing soft tissues, shortening the bone, and allowing early range of motion of the joints. So how much do you shorten? As much as you need to. And where do you do it? In the top of the femur. So that's this patient afterwards. Same patient. Not sure how to start these. These are videos, but there you go. And that's her afterwards. So we can do this with a pretty major incision, both on the front and both on the sides of both sides of the knee and on the thigh, and basically eliminate all the tissues you need to be. If you don't like surgical pictures, turn your head now. That's this patient, and there you have the surgery itself, and that's the knee afterwards, and that's what we do for it. So I took out the gory pictures. But basically the goal of the talk of this talk was to show you that even in conditions that have no range of motion, you should be able to maintain the range of motion. And this is one of the children with my wife, teaching my wife how to stand up after the surgery. So I think that there's a lot that could be achieved using some newer techniques in these conditions, which is about a 1 in 8,000 births to allow for motion of the joints. So thank you for listening. Happy to answer any questions, but I appreciate it.
So if you've got any questions, please raise your hand and do name yourself, and also if you've got any particular questions and which entity you represent. So if you've got any questions.
So I'm going to start, David. This is a really, really good talk, and I mean, it tells us how much we're blessed to even walk. These are kind of things that for granted that when you see these kids, what they're going through, it's very emotional. My question to you is that so I understand that the recovery period takes sometimes like time to build the muscles, etc. What would be your advice for patients who wants to travel abroad to do this? Are we doing this here in Abu Dhabi, and what's the value of the rehabilitation other than the surgery? Because the surgery is part of the treatment, but there is much more to add to it.
Yeah, I think I'll answer both. The second question first. So I think in both of these conditions I showed, there's no doubt that rehabilitation is a major part of their recovery. Both if you're paralyzed before you come in, or partially paralyzed, or if you have arthrogryposis, the arthrogryposis is just as important to do the rehabilitation as is the surgery. So in the second one, in arthrogryposis, that we certainly can do in Abu Dhabi. And then they just have to make sure that they're in a location where they can get the appropriate therapy that either is managed by us or managed by the people where they are near home, and work with us, either our team in the States or the team here, to make sure they're getting appropriate care for the rehabilitation. In the second one, the condition that we're trying to set up in Abu Dhabi, and probably next year we'll be doing in Abu Dhabi. Right now, we do that in the United States. But again, they would come back here for the rehabilitation. I mean, spine surgery is easier to return home sooner than limb surgery, because spine surgery is one and done. You're finished the surgery, you can return home relatively quickly within 3 to 4 weeks, and then you do the rehabilitation at home or with a therapist at home. And oftentimes, because of virtual appointments, even with our therapists, they can do that and manage the therapy at home. Limb surgery requires more intensive rehabilitation, and they have to be in a location where they can almost do the therapy every day. So if they're in a place, if they're in Abu Dhabi or close to Abu Dhabi or near Dubai, it's probably fine. If they're somewhere a few hours away, it's probably more difficult.
We have another question here. If you can mention your name and the entity.
Hi, my name is Caroline Bilen. I'm the founder and CEO of the Compass Health Consultancy. I would love to ask you, doctor, what is the main challenges as a surgeon you face during this procedure?
Yeah, thanks. So I think that the two different procedures I showed. So actually the one I showed, the last case I showed from arthrogryposis, that actually was a child from Ramallah, who I did when I was on the West Bank. That was actually a child that I treated abroad, and I did that abroad, and he did just fine. So that, I think the challenge is for the aftercare is the biggest question, is that we can do the surgery, but what, as Ibrahim was asking me, what happens afterwards? So that for those surgeries, that's the biggest challenge, and how the patients are going to get continued care afterwards, the bracing, the physical therapy, and things like that. I think for the first operation, the biggest concern I have is really having the right team available, because when you do those cases on dwarfs, you know, you need the appropriate neuromonitoring, you need the appropriate anesthesia, you need appropriate, the equipment that we use is really highly technical, from ultrasonic scalpels to navigating every screw that we put in, to trusting our neuromonitoring and the anesthesiologist with the blood pressure availability, and then afterwards to make sure you have the care to take care of those patients afterwards, the correct hospital. So I think that the biggest challenge for me as a surgeon is to create the team, which we've done in the different locations that I work, but that was the biggest challenge.
Thank you.
Are there any more questions? We've got another question over here.
I am Dr. Sadish. Can we prevent this completely with the medical treatment, this arthrogryposis process?
So I'll talk about both conditions. So in arthrogryposis, we cannot prevent. Arthrogryposis is it's a non-denominational, non-genetic disease. There are some genetics involved, so there are some places where it's more relevant. But AMC is a non-genetic form of arthrogryposis, and no one understands why it is. Is it viral? Something caused a migration defect in the notochord? No one knows. So it is not preventable. It is not treatable, either by stem cell or any other way. Perhaps someday it will be, but as of now, not. Genetic forms are becoming more common because we're getting better genetically in seeing things and in understanding that variabilities of unknown significance are probably significant. So when we get a genetic test and it says VUS, variability of uncertain significance, it probably is significant. You just have to find the right significance. In terms of the first condition, achondroplasia, there are a number of companies now making medications given to young children for the condition. The question is, will that drug help the spine? There's some preliminary data that says it may, that the pedicle may grow if we give the drugs early enough, the FGFR3 inhibitors, but no one knows for sure yet.
Thank you.
Are there any more questions? Please raise your hand if you've got any. Well, I think that wraps it up. Thank you very much, Dr. David Feldman. Okay. Yeah. So we've got more information. Oh, sorry. If you've got more information that you'd like to find out as well, you can go over to the QR codes that we've got around the Burjeel Medical City Pavilion as well. And another interesting story